Yeah, we've done studies that have used solutions containing anywhere from 2 grams per 100 ml up to 20 grams per 100 ml. At 20 grams, you know, it gets a little on the heavy side. And I've even seen cross-country skiers who have taken hot tea and saturated honey in it, which gives it somewhere around 40 grams per 100 ml. And they can consume that if they consume small quantities. And it seems to be that the amount of improvement in performance is almost proportional to the amount of carbohydrate you can get into them. Of course, there comes a point where your stomach's going to revolt because you just can't get that rich solution out of your stomach. But surprisingly, in exercise with small feedings, it does seem to empty fairly well.
Thank you. Could I ask another question?
Sure.
In reference to that, do you recommend a warm solution of water or a cold solution of water?
Yeah, I had a big argument. I studied the Swedish national cross-country ski team somewhere above the Arctic Circle. I don't remember where. But they were totally convinced that a warm solution would empty from the stomach faster. And so they always kept their tea in a thermos on the trail. In looking at our studies in the laboratory, it's just the opposite. That is, cold solutions seem to empty faster. And that's been shown by a number of people clear back in the 1930s. That was shown. So it seems as though it'll empty a little bit faster if it is cold.
Can you comment on percent increase of the basal metabolic rate of a person who's exercising maybe 3 to 4 times a week and is desiring weight reduction?
Do you mean the effect of the basal rate of energy expenditure on, say...
Like over time, will it actually increase their metabolic rate? A lot of clients are yo-yo dieting and metabolism becomes sluggish. Will exercise help too?
Unfortunately, this is probably a bad bit of news, but when you're doing chronic heavy exercise, the body perceives that, especially when you're in a little negative caloric balance, the body normally perceives that as starvation. So Rick and I were talking earlier, and I mentioned to him the fact that a lot of times when you look at people day after day after day who are in hard training, if you knew nothing about their exercise program, you just looked at their blood profiles, they'd look like they were in starvation. So the body perceives that as a negative thing. So what it does is it tends to reduce your basal metabolic rate, which is just the opposite of what people want to do who are trying to lose weight. They'd rather keep their metabolism a little elevated. So what happens, unfortunately, is that you do get a small reduction in metabolic rate, which means that you're going to burn off fewer calories in between your exercise sessions. Probably more reason to maintain an active lifestyle, because any little activity in the day will keep your metabolism up a little bit.
What do you recommend as far as frequency of exercise in a week for someone who's desiring weight reduction? Like how many days?
How many days of exercise?
A week.
Well, you could probably do 5 or 6 days a week if it's mild, fairly low intensity. It's pretty hard to train at a very high intensity every day for that many days unless you're training for sport or some serious event. But I think 4 to 5 days is not unreasonable as long as it's something that's not too unpleasant.
Can you tell me how important it is to have electrolyte replacement fluids for, say, athletes who are like football players, non-endurance sports?
Your question is one that's fairly common, and that is most people think that because their sweat tastes salty and they're losing salts and water from the body that they probably ought to be drinking their own sweat. That's not a very good idea, not a pleasant thought either. But a lot of people are afraid that you're going to become hyponatremic or get a potassium deficiency if you don't take in some mineral. The body is amazing in its ability to compensate for all the things we do to it, and nature seems to have good backup mechanisms. As you know, your water and mineral content is regulated very nicely by the kidney. When you exercise hard, the kidney simply conserves. you know that if you don't exercise today and you consume 300, or maybe not that much, say 200 grams of sodium, that in the next 24 hours you'll urinate off 200 grams of sodium. And that's the way you maintain a balance. If you exercise hard, you'll conserve. We've seen people who will only urinate off 10 to 20 grams of sodium a day. And so the body does a pretty good job. In one single meal, you can replace nearly all of the sodium, potassium, and most of the trace minerals that you would normally lose in any training session. So we really don't feel that it's necessary to have it. It's like the vitamin deal. Probably not going to hurt you because, again, the kidney will dump the excess. So it's not a hazard, nor is it any great advantage unless you're competing in a 24-hour run. And then you might get into trouble because then you sweat for too long a period and you have to take something in. Yeah.
We have a call-in question from Penn State University in Pennsylvania. And the question is, could you comment on the use of anabolic steroids? Specifically, do you really mean that the anabolic steroids are needed to build muscle in athletes? And if so, what about the other effects?
Well, of course, not everyone who has big muscles, at least bigger than mine, are going to need to have anabolic steroids to build muscle. The normal androgenic effect of our hormone system allows some individuals, of course, to develop greater muscle hypertrophy, that is to develop the size of the muscle more than some others. Probably the point of all of the interest and concerns about anabolic steroids is that they're effective in doing, in some people, what their own natural systems can't do. And of course, you see that very obviously in women who lack the hormone system to be able to produce muscle hypertrophy, especially in the upper body. You can see in the female bodybuilders these days, the upper body development's unbelievable because it's not hard to tell whether they're on steroids or not, because a woman who is not taking steroids will have a very, very small increase in muscle size in the upper body. So there's no question that the steroids have that effect. However, what I'm pointing out is that by manipulating your diet, you're not going to produce that effect. You're probably going to only produce some effect in hypertrophy by hard overload training and strength work. So I don't think there's a contradiction there. I think it's simply that the steroids are simply doing something that, quotes, is unnatural.
We have lots of these questions, Dave.
Oh, should have mentioned that.
Don't bother to walk over to the seats because you can see that he worked me pretty hard when I was his student. I'm going to work him hard now. Have you any studies or information about the effect of weight loss by student athletes prior to wrestling meets in order to compete at certain weight levels?
Well, being in Iowa and talking about weight loss in wrestlers is like being in Rome and talking about the Catholic religion, I guess. But no, I think there have been a lot of attempts to try to regulate the problems and the attempts by athletes to lose weight in order to move into a weight category that gives them an advantage. I find that very paradoxical because you end up with two guys who have lost enormous amounts of weight to get down to a certain weight category, both of them now undernourished, competing in a weight category that neither one of them should be in. And then they're usually given some time to, after dehydrating to make that weight, they're usually given some time to take fluids back in. So now they're heavier than their weight category, competing in a weight, I don't understand that whole system. But the point of all of that is that in order to be at an optimal training weight, the only thing that can really be manipulated to some degree is the fat content. If you're going to do it from a common sense point of view and quit trying to manipulate body water content, it's obvious that they have to reduce body fat content down to a reasonable level. What is that reasonable level is another debatable point, because our techniques for measuring fat are not all that perfect. And probably to say that someone should be allowed to go down to 6% or 8% body fat and claim that that's okay can be a little scary too, because our measurements may be far enough off that we may not be accurately predicting their fat content. But in all, the bottom line of all of it is, if they're going to control weight, they probably ought to lose the excess weight before they begin the training period or in the early stages of training, rather than to try to go through these extreme methods of use of diuretics and sitting in saunas and all kinds of methods for losing excess body water. So there's not an easy answer to that one, and it's a very controversial area.
Okay, this question comes to us from the Atlantic site, Extension Home Economist. There would like to know, is glycogen replacement enhanced by eating within 30 minutes of exercise?
Well, I did see a paper just recently that suggested that some individuals may benefit by feeding in the last 30 minutes before the exercise. Our studies have shown that that's pretty risky, because as I pointed out to you, if you elevate insulin at the start of exercise and you begin muscular activity, the combination of high insulin and muscular activity will remove blood glucose very, very rapidly. And the risk in some individuals is that they'll have a failure in performance rather than any enhancement. So I think it's a bit risky. There is good evidence that a pre-competition feeding is important to enhance performance. So, but that should be a couple hours earlier, I think.
And from Jackson, Ohio comes the question, is there a nutritional problem with female athletes that train to the point of amenorrhea, and what could be done if there is?
Yeah, there are a number of questions related to amenorrhea in female athletes, mainly because of the questions of osteoporosis and difficulties in calcium retention and even iron deficiencies. There's pretty good evidence today that individuals who are training, especially females who are training very, very hard, may have some iron binding problems, and the consequences are, some sports anemia. So those are things that should be monitored rather closely. So certainly we need to look at ferritin levels and the ability to incorporate iron into the system in some individuals. But that doesn't mean that everyone's going to become anemic who goes into hard training. I think that we have to be concerned with the health and the special nutritional needs of the female athlete, though.
Well, thank you, Dr. Kostel, and we'll break now for our lunch break. We appreciate your candid remarks about these problems in nutrition. Pardon me? Oh, hold them one moment. Okay. I'm sorry, I shouldn't let you go yet. Oh, I thought I was given a note to save them for the panel. Oh, okay. Well, we can take more questions then. I'm sorry. I apologize. Well, we have plenty here for you, Dave. You want to deal with that one?
No. We already answered that.
Yeah. This is a question that comes to us from Woodbury, Connecticut, and the caller would like to know, how do you know if you are a person who could suffer from exertional hypoglycemia?
Well, the symptoms we've seen in exertional hypoglycemia, of course, are typical of what we see very often in juvenile diabetics who get into trouble with very low blood sugars. That is muscular weakness, and there are some borderline problems that have been described by some in that is they begin to lose their vision and feel faint and feel so weak that they literally have to stop. That's fairly rare, of course, and the only solution seems to be, of course, never to eat anything right beforehand, and perhaps to have some carbohydrate supplement carried along, that is candy or anything that could be helpful if it were taken during the exercise itself. I get that question most often from, it seems, very thin females. I don't know why. But it is a common, not an uncommon problem, it seems. At least in every audience, there are a few people that have had that problem.
And from Storm Lake, Iowa, would you recommend any specific carbohydrate drink during an activity?
No, I think we addressed that earlier, and that is that I think you would just look at its carbohydrate content rather than to look at any particular commercial product. I mean, you see them advertised. Most of them are pretty good. I don't see anything that's really any big advantage one over the other. And there are a number on the market today that do a job very well. You could probably mix your own if you wanted. The big problem is getting something that is flavored right. I should warn you that flavoring in drinks changes dramatically from sitting at the kitchen table to being out in the middle of an exercise bout. Your sensations of taste are drastically altered. Something that tastes great when it's mixed with alcohol or something doesn't taste very good when you're exercising hard, because in exercise people prefer something that tends to be very mild and have very little aftertaste. There's nothing worse than a very strong taste in an activity that can make you fairly ill fairly quickly.
Didn't you try drinking Mazola oil once?
About that.
Yeah. Fortunately, it didn't get to the students.
It didn't get beyond my stomach.
Right, yeah. This is a question from the Swenson Center for Nutrition in Omaha, Nebraska. What practical guidelines would someone like a swimmer who trains twice daily what are some practical guidelines of a swimmer who trains twice daily in regard to the carbohydrate intake and meal timing?
Yeah, that is a problem we've dealt with, because we've studied swimmers who have gone through hard training, 4 hours a day, 2 in the morning, 2 in the afternoon, and we've tried to see how we could take care of the individuals who do tend to break down. There are people who tend to undereat. Even though you increase their normal training, they don't increase their caloric intake. And that seems to be a very difficult problem to face. They seem to be the same people all the time. So what we've had to do with those individuals is to give them a liquid carbohydrate supplement. That is, I know Ross Laboratories and others produce whole meal, that they can take that's very high in carbohydrate. And that seems to be a good supplement. The reason we do that is at least we know that they're getting a definite level of carbohydrate, and we feed it to them immediately after the morning session. Because what often happens is they'll train hard in the morning and then they won't eat breakfast. And that happens to a lot of athletes. So we make sure that they're getting at least some known quantity of carbohydrate, and it seems to be the only way we've been able to prevent those particular individuals from becoming chronically glycogen depleted. Do you have a question? Yeah.
One, I've been reading lately that people that are exercising for weight loss, that exercise only like 20 to 30 minutes, are really not doing that much to get weight loss. They should be going 50 to 60 minutes. And the other question is, how much should you drink like the morning before you're going to run in, say, a 10K race? The amount of fluid.
You're going to have to remind me of the second one, because my memory is terrible. Well, actually dealing with the second question about how much fluid you would take beforehand, if they're running, say, in a 10K race, what I suggest very often is that they have a drink just in the minutes right before the start. The problem is if you drink too much in the hour or 2 hours beforehand, your performance times will be terribly slow because you'll have to stop and urinate someplace. And so you don't want to take it too early so that the body can end up dumping the excess. But if you take the drink in the last 5 minutes, that's too short a period of time for the kidneys to do much about it. It's in the gut and it's being taken up then into the blood. And once you start exercise, blood flow to the kidneys is reduced and your reabsorption of sodium and so forth is accelerated, so you don't tend to dump much fluid. So I would recommend the volume you take in is somewhere between a couple hundred ml all the way up to 8 ounces perhaps. So it depends on you. The advantage is you start off with a water reservoir in the stomach that you absorb in the minutes, initial minutes of exercise, and that's a plus. And what was your other question?
About the length of time to get maximum weight reduction for exercising, aerobic exercise.
I mean fluid
No,
loss?
how long you should exercise. I've
Oh,
read lately
yeah,
that 20
yeah.
to 30 minutes really doesn't do that
Yeah.
much towards fat reduction.
Well, I would question that. I think there is, in 20 to 30 minutes of vigorous activity, you're burning, it doesn't sound like a lot of calories. Sure, you may only burn, say, 400 calories in that period of time. That doesn't seem like much out of, say, 2,500 for a male or 1,500 as was cited for females. That doesn't seem like very much, but it accumulates. And the point is, a little bit today and a little bit tomorrow all adds up. So over a period of days, you do gain the advantage. I don't know that you necessarily have to you go an hour a day or whatever in order to lose any weight. Again, it's probably preventing yourself from increasing your caloric intake as you start doing that activity. That's the hard part. Yeah.
Along the same lines, I think this is a pretty intriguing question and one that we're faced with a lot lately, it seems anyway. How does swimming rate as a means of reducing fat, particularly as compared to running as the mode of exercise?
Yeah. That's a big question, and I've tried to look into that problem because obviously if we took a group of male or female swimmers and we stood them up next to a group of female or male runners, you wouldn't have any trouble telling which was in which group, because even though the swimmers are training 4 to 5 hours a day sometimes, they retain body fat. Now you'll say intuitively, oh, that's natural because they're in cold water all the time, like seals or something, I don't know. So they keep that as thermal insulation. Well, there's no evidence that that's true because they develop a fever, swimmers who are training develop a fever just like runners do. So the question is, why don't they lose their fat? We have no idea, and we've looked at hormone differences, taken triathletes who are trained at both activities to see whether there's something different when they run as opposed to when they swim. And we can't really pin that one down. But there does seem to be some greater difficulty in losing body fat in water exercise. And I'm not quite sure why it occurs. Part of the problem is that most people who get into fitness or get into swimming training aren't very proficient at swimming. So their ability to expend much energy is relatively low. They may spend a lot of time in the water, but that doesn't necessarily mean that they burn a lot of calories. So that's the other part of the problem. So I'm not sure that we really have an answer to that. I think it's a really intriguing problem, because I always thought a calorie was a calorie until I started looking at swimmers and finding that if you monitor the diet of a runner and how many calories they burn every day, you find that they tend to overeat. They eat more calories than they're actually burning. If you take a swimmer, they burn more calories than they eat. But the body fat content of the two just is almost reversed. You'd expect the runner to be fatter than the swimmer, and that's not the case. So I don't have an answer to that, but it's really, to me, one of the more intriguing questions and problems. Yeah.
Okay, thank you, Dr. Kostel. We'll let you go now. I might remind you all to keep those minds working if they aren't glycogen depleted by now. This afternoon we will have the panel discussion, and we'll be happy to entertain any more questions concerning some of these issues at that time. At this point, we'd like to break for the luncheon, which is ready to be served supposedly in a couple of minutes here at 11 o'clock, and that will be held up stairs near the registration desk.
Nutrition Center, New England Medical Center Hospitals in Boston. She recently served as a featured speaker at the 71st Annual American Dietetic Association meeting, where some of you may have heard her. She has written numerous articles on nutrition which have appeared in medical and scientific journals as well as in the news media. Here to discuss some of the behavioral aspects of nutrition fraud, my friend, Dr. Johanna Dwyer.
Thank you, Dr. Runyon. If it hadn't been for you, I never would have gotten my degree. Jackie and I studied together for our orals at the Harvard School of Public Health only a few years ago, Jackie. Just 2 or 3. Yeah, it just seems like it was. Well, before we start this lecture and talk and discussion with you, I'd just like to thank the people of the great state of Iowa for a personal favor they did. Could I have the lights down? This is a memory of something long ago now, but it's one of my favorite cartoons from the 1988 presidential elections. And as you know, our governor from Massachusetts came out here, and you were kind enough to award him votes in the primaries last year, just around this time. And this is my favorite cartoon. It says, Dukakis Farm Policy. They were teaching him, this is a cow, this is a horse, this is... Well, it didn't do much good, but we're lucky to have our governor back now, and we certainly appreciate him, perhaps more than the voters did. Well, let's just take a little more serious note now and focus on some unproven dietary remedies. And let me just define what I mean by unproven before I start, and I'll come back to this later. What I'm talking about here are methods that are promoted for the use, dietary methods, in prevention or disease treatment or rehabilitation, which scientists and expert clinicians, after reviewing the evidence, deem not to be effective. This isn't quite the same thing as the notion of alternatives, and I don't think the terms are interchangeable, and we can come back to that and perhaps talk about it during the discussion. But I just wanted to get that definition out on the floor. Now, there are a whole bunch of things, and I think the next speaker is going to cover some things that I won't be talking about. I'm just going to concentrate on the upper left quadrant of this slide, the food remedies. But if we took all of them together, if we took all unproven therapies for all these different diseases and conditions together, not just the behavior-related ones, but all of them, and the drugs and the clinics and everything else as well, I think most of us would agree this is a fairly conservative estimate. The things that bother me enormously is the cancer and the AIDS, and particularly the AIDS. I come from Boston, and we have a fair number of AIDS cases now, and these people are being victimized. Somebody is usually making money on some of these things, but in other cases, it's just a question of people not knowing. Mrs. Stevenson this morning had some very useful observations on this, where she was talking about some of these things that have come in that people get into because they think they're useful, and it's not necessarily that they're making money when they tell their friends, but sometimes that's the case too. Well, the basic thing is that sometimes statements like "I believe in" or really seeing isn't believing. We were just talking about psychic surgery during the lunch break, and I'm sure that'll come up during the question and answer period. And it seems as though these folks are doing something that's really unique, but in fact, seeing isn't always believing. And believing may not be scientific, and so this is some of what I need to talk to you about today. I just have to mention one illness that's one that afflicts a lot of people in my family. These are some of these bracelets that the arthritis sufferers wear, and I'll leave the bracelets to other people. I'll just concentrate on the mouth and on food. Let's just talk just very briefly about the difference between conventional therapies and investigational therapies. That is things that are being tested experimentally in clinical trials. And this is really what we mean when we talk about the tradition of science. This is at least what we strive for in testing things scientifically. We come up with hypotheses or hunches about the fact that a food or a drug works. We make a hypothesis. We figure out a way to do a careful test of it. We test the feasibility. We also make sure that whatever we're doing doesn't do any harm and conforms to ethical standards. And then we go ahead and try to set up a clinical trial which compares some standard treatment for a condition to a new treatment, for instance, a new drug. Sometimes it's a new dietary therapy. And there's several of these sorts of trials that have been done, some which I won't talk about today, but that are, I think, that have been studied very well in the nutrition field, have to do with some of these dietary therapies for various behavior disorders. In the work at the University of Wisconsin, for example, where they studied some of these diets that are low in sugar and low in various food additives versus diets that were higher, demonstrated, at least to my satisfaction, fairly conclusively that these particular diets didn't seem to have a role in the treatment of this particular disorder, at least in most children who suffered from it, that other things probably were more efficacious. This is a powerful tool that's used extensively now in medicine, testing new treatments, whether they be drug or diet treatments. And I have the privilege to be involved with a couple of clinical trials which are testing hypotheses of this sort with respect to diet and chronic degenerative disease. One of these trials tests low-protein diets in people with early end-stage renal disease. Another trial, which is no longer going on, tested the feasibility of very low-fat diets as possibly something that would decrease the incidence of cancer of the breast in women who are at high risk of breast cancer. So this is the method that we're talking about when we talk about the method of science. Now, when we're talking about experimental treatments or investigational treatments, where we're trying to find out if diet has a role, whether it's in behavior or some disease process, and we test them in these clinical studies, these are the kinds of characteristics which we like to see. Can everybody see these slides? Yeah? Okay. One thing is, has the treatment that we're testing shown some merit in initial tests, whether it's human or animals? Secondly, is the test really the one that's the best bet? We don't have endless time and we don't have endless money, and so there are 1,000 things that could be done. What we have to do is zero in on the few things that seem like the very best bets of all the possible things we do. And this is why every conceivable thing hasn't been tested. We just don't have the money to do everything we'd want to do. But where the evidence is such that there's a reasonable doubt, very often this is a useful technique. Sometimes the evidence is so overwhelming that something is not likely to work, then we don't need to go ahead and do this. Another thing is to make sure that the kinds of things that Mrs. Stevenson Agency does, if we're testing a diet-related thing, that it's pure, that it doesn't have some other problems. And one of the problems with some things we get that are on the clandestine market, whether it's for whatever disease, is that this isn't true, that we're not sure that the food or the drug is pure. We want to make sure that the people who are in these tests stand to benefit in some way. And finally, of course, in any kind of test that we do, we must be sure to abide by ethical standards and make sure to disclose to the people who are being used in the experiments all of the risks and all of the benefits. Well, why is it that people, before I go into some of the specifics, let me just talk for a minute at least about why it is that people seek unproven dietary remedies and some of the psychology behind this. And I'm sure some of the other speakers will have much more to say about this during the question period this afternoon. Let me just spend a minute focusing on this diagram. Just a second, I'm going to get a little pointer so I can. Okay, what this does is to try to illustrate the various factors that contribute to the choices that people sometimes make for treating self-treatment or maybe even treatment through medical sources for various diseases, for various conditions and problems they suffer from. Here's the poor person right here. Okay, there are at least 5 things we need to consider. We need to consider the person themselves. We need to consider the disease or the condition that they're dealing with, whether it's premenstrual syndrome or TMJ syndrome, some of the other things I'll use as illustrations. We need to consider the physician or the healer. Sometimes it's not a physician, it's somebody who has that role of being involved in the advice giving. We need to consider society as a whole. We also need to consider the therapy. So let's just focus first, just make a few brief statements about the therapy, and then I'll focus on these others in greater depth. One thing that's very important, and I think we'll find out when we go through some of the examples, is that sometimes there isn't a very good alternative for a lot of things, whether it's a behavior problem, attention deficit disorder, some mental forms of mental illness. We can treat things symptomatically, but we don't have a silver bullet the way we do with some infectious diseases. And so for these sorts of conditions where a definitive therapy doesn't exist, these unproven remedies very often do very well. And a second thing about the therapy is how effective standard treatments are. Some of you perhaps suffer from migraine, and you know that there isn't any really perfect way to solve that particular problem. And one can see when there isn't a definitive answer how it could be that diet would creep in as something that seems to be the answer. I have a very good friend who's a very well-known professor of nutrition at a well-known Eastern college of education who suffers from herpes. And she told me a couple of weeks ago about it, how difficult it was with herpes. It's so difficult to know what's causing it and what's setting off the reactions. And the itching is so difficult that she said even she was thinking of all of these dietary connections, even though she knew there weren't any. So we can see how the therapies, when the therapies aren't good for a disease or a disorder, it's easy to have diet be the answer, or at least for us to turn to diet. Okay, well, let's start and think first of all about the whole issue of what kinds of things in the person or the patient. I work in a hospital, so I always put patient up there. I guess I should put person. What kinds of things might lead a person to pick a method that's really not something that seems to be very efficacious from the standpoint of scientific experts? Well, some people have said it has to do with the social support system. And others say people who want to be self-reliant perhaps have more of a tendency this way. Their individual coping styles may be such that they find that these offer some promise because they can do things on their own. Sociocultural background has already come up today as something which may influence us. Some of us have been taught since childhood that taking lemon tea or chamomile tea or some other kind of tea when you have a cold is absolutely the way to go. Others of us have been told to take Irish whiskey. In all cases, the colds seem to go away sooner or later in most cases, but it doesn't seem to matter what you take. I think my own recommendation as a nutritionist, even though I'm of Irish descent, would be the tea. And then there's a whole issue of health beliefs. Some people, this whole theory of where is the control? Is the control within yourself or is the control outside of yourself? For some people who like the control within themselves, they may find it helpful to be able to control their diet or at least to think that they're controlling the disorder or condition. So it's easy to see how diet creeps in. Well, what about some other things? Well, one is the people outside, whether it's a physician or a nurse or some other kind of counsel or either lay or professional. Certainly these folks also have something to do with the use of unproven remedies. So for physician, read healer, counselor, or what have you. Their attitude, if you hold a person in respect, the attitude of the person you're seeking advice from in terms of unproven treatments will also have a great deal to do with whether you use that treatment or not. Communication skills of the person also are very potent determiners. Education and training. Many people come from, perhaps from parts of the world where things like psychic surgery or something that they think are just everyday things, even though there may not be much to it. Social, cultural background, and demographics, all of these things may play a part. Well, what about the disease itself? This is something that I'm fascinated with and something where I have several colleagues working actively with me right now. We're interested in looking at the kinds of diseases that seem to be particularly likely to cause problems. And I'll mention some diseases, and then we can talk about some disorders of other sorts. Some of the ones we're particularly interested in are things like multiple sclerosis, Parkinson's disease, arthritis, certain forms of cancer, which we'll be talking about later. Another speaker will be talking about that. Some of these diseases which are severe, they're chronic, they come and they're there for a long time, which have substantial, they make you pretty sick. Sometimes they're fatal. They don't have a course that's something you can predict. It's like the herpes example I just gave. You can't tell. It just seems to come out of the blue, and you keep trying to find a pattern, but there doesn't seem to be any pattern there. Where standard treatments aren't very efficacious, where nothing seems to work 100% or even 50%, and where the disease is fairly prevalent. All of these things seem to be something that are particularly likely to cause problems. And some other examples are some of the attention deficit disorders, mental retardation that doesn't seem to be explained, mental illness, schizophrenia. People really don't understand what's going on, and these, again, lead to diet being thought of right away. So we've got a whole bunch of things that are affecting choices of therapy, and it's not just any one variable. This means it's a complex educational process that we've got to do to change things. I didn't mention society, and of course, society will also have a great role here. The mass media, I think, are being used today for purposes of the angels, but sometimes quack remedies get on TV, and they get onto talk shows, and as a result of that, people pick them up who otherwise wouldn't see them. Some societies have more social stigma or discrimination, which they attach to certain treatments than others, and this can influence the use of unproven remedies. And finally, the whole issue of access to care, cost and availability of care is also important. So that's just a little background. Now, what are some of the common bonds of unproven methods? What kinds of things are often common? Well, these are some of the things. The scientific tests are often lacking. In other words, there hasn't been a clinical trial for the particular remedy in question. Sometimes the anti-establishment element creeps in too, that somehow somebody is hiding the truth in the establishment. There is a huckster approach sometimes. Some of these PMS clinics that are springing up around the country have done very well, and they make a lot of money. The sensationalistic media approaches we've seen with a lot of the treatments, particularly for some of these difficult chronic degenerative diseases. A heavy reliance on testimonial data and appeals to the emotions. All of these things certainly don't appeal to most of us, but do enter in as a problem. Well, what are some of the code words of these unproven methods? Let me just mention a few code words, and again, we can discuss this more. Orthomolecular, preventative instead of preventive, ecological, unorthodox, holistic, nutritional. Those of us who have spent our lives trying to find the truth sort of resent the fact that this is on that list. Metabolic, natural, alternative. Let me just spend a minute on that. Why is it that methods that are unproven really shouldn't be called alternative? Well, in my opinion, an alternative means an option that's equally good, something that's equally good to something else. And in most cases, what I'm talking about, these unproven methods that the best minds that we can find to judge these things find after review of all of the evidence aren't efficacious, are not alternatives at all. They're not as good as standard therapies, and therefore that word should not be used for them. Non-toxic and unconventional are two other words that are constantly used in that. Now, why is it, if these things are all of those disadvantages that I've just mentioned, why is it that there's so many unproven dietary remedies? Well, I think we have to look at both the pros and the cons of these unproven remedies. One thing is the whole issue of placebo effects. That is, effects that are due to something other than perhaps what we think they're due to. And placebo effects can be very potent, as you know, with many things, many disorders, because of the way they present. Usually you don't go to the doctor with a headache, for example, unless you've had a lot of cluster headaches right in a row. So when you go, even if all they say is go home and see if it gets better, it usually gets better. If things are clustering in time and space and you go right at the time they're the worst, the law of averages is they're not going to get worse right after they were worse. So time heals a lot of things, even if there's no cause and effect between diet and what's going on. Let me go down the pros first. The second thing is the whole notion of personal control. Diet is something that we control ourselves, or at least we try to, and we receive, some of us receive a special kick out of being able to control things and using therapies where we control what's going on instead of having control outside of ourselves. The third thing is the whole notion of remedies for helplessness. And someone who's afflicted with migraine headaches or afflicted with difficult to manage feelings or behaviors, or who feels helpless with a child with Down syndrome, who has such difficulty coping with things in life, feels good if they think, well, maybe a diet can do something. And this is why diets, I think, were so popular for some of the attention deficit disorders, hyperactivity. And then the thing about positive attitudes. Very often, this is an upbeat thing that's marketed and sold upbeat, and it really gives us a positive feeling, and therefore we think that this is the way to go. Well, what are some of the cons? I'll come back to this at the end, but basically, one danger is delaying or replacing present care. A second danger along the same line is a notion, which we talked about again at lunch, that when these unproven remedies are used for people who are very, very sick, they also have more money to perpetuate them with people who might otherwise seek some alternative treatment that could help them at earlier stages in their diseases. We'll come back to that again. They're harmful in and of themselves in many cases. There's a treatment that would work, and this doesn't work, and what's more, it may cause harm. And some of the diets that we see, for instance, macrobiotics diets for some otherwise treatable forms of cancer, I think are harmful in themselves. They may be deceptive, and certainly they're very expensive. So that's just the background in terms of unproven remedies. Well, what about diet therapies specifically? What is it about them? Well, one is this very, very important thing I think we always need to be remembering when we're counseling our clients or patients or audiences, that people want to take control of their own lives. And so whenever we can give them something that they can do themselves, whether it's diet or whether it's some other alternative, for instance, some of the relaxation techniques and pain management strategies that may be helpful and which I'll mention later, these are important things that we can do. The second thing that diet therapies do to people is very often they give them a sense that they're fighting back and acting positively. My plea is that let's make sure when we use diet therapies that the ones we use are efficacious. When there isn't an effective diet therapy, I think there are always other things we can help people to do that may be effective in dealing with their problem, even if the condition itself can't necessarily be cured. At least we can help a little bit. Now I'd like to go on to talk about some specific conditions that influence people, some which have to do with behavior, some which have to do with feeling terrible, and spend a little while just illustrating those points in a larger context. The first condition I wanted to talk about was dysmenorrhea, or pain associated with menstrual cramps. And very large numbers of women suffer from this disorder. It gets up to 40 to 60%. There are probably two types of dysmenorrhea. One is called spasmodic, and it involves nausea and vomiting. It's fairly short and specific in the 24 hours period right around the onset of menses. A second type is congestive, and it tends to be a duller ache in the lower abdomen and back, and to take longer before it resolves. But those are two sorts of dysmenorrhea, and this afflicts rather large numbers of women. Now the cause, there are many possible causes. One is uterine dyskinesia, another is myometrial ischemia. There are a whole bunch of possible gynecologic causes. There's very active work right now looking at prostaglandin production, especially in the endometrium, and that this may affect it. What about diet causing it? Many people think, well, maybe if I eat differently or something, that will change the way I feel and change the cramps. To the best of our knowledge, diet doesn't seem to affect this particular condition. So the treatment is not diet. Some of the treatments probably include heat, warm baths, analgesics, rest, and so forth. Some of the newer treatments, which involve behavior therapy, have limited success, but perhaps are more fruitful to pursue than diet. And I just read a review of this, some interesting studies on this. One are some pain management techniques that have to do with trying to limit concentration on the pain. Another technique that seems to work in combination with this is muscle relaxation techniques. And these sorts of behavioral medicine therapy seem to do fairly well. They certainly don't do perfectly, but they do seem to be more efficacious than the dietary remedies. So what I would suggest, at least for this disorder, is that this isn't something where low-salt diets, limiting fluids, not eating anything is likely to do good, at least for most people. Let's go on to another possible female condition, and that's premenstrual syndrome. Now, premenstrual syndrome, again, is something that's defined in various ways, but I guess the way I'd like to define it today is subjective reports of psychological or bodily symptoms and signs occurring consistently after ovulation, but prior to the beginning of menstrual flow and menses. So you shouldn't confuse it with dysmenorrhea or menstrual cramps. And usually these symptoms cease for at least a week after menses. So in a sense, timing is more important than the exact symptoms. Now, I wanted to just acknowledge my colleague and graduate student, Virginia Casey, who did, I think, a very good article on this that appeared in Nutrition Today about a year and a half ago. It was, I think, November, December 1987, where there's a much more complete discussion of this syndrome than I can do right here. And Jenny is working on her PhD, and this is one of my favorite slides. It says, an excellent defense, let's give her the doctorate. And I think this is an excellent defense of her views on premenstrual syndrome. Well, one of the most famous Massachusetts residents, after the one who came out here and pleaded for your votes a year ago, in the history of all mankind is a lady, and her name was Lizzie Borden. And I just asked Dr. Runyon, because I can never remember. I have a bad memory. I need lecithin, I guess. And I just couldn't remember. Actually, I don't need lecithin at all, because it doesn't work. But Lizzie came from Fall River. And how many of you out in television land remember the poem that you learned when you were a little boy or girl? And that was, Lizzie Borden had an axe. She gave her mother 40 whacks. When she saw what she had done, she gave her father 41. Now, the reason I bring up poor Lizzie lived in Fall River, Massachusetts. This all happened back around the turn of the century. And the Borden family was very well known in Massachusetts, especially down in Fall River. And her defense was based on the fact that she suffered from premenstrual syndrome. I think she also suffered from not liking her father or her mother. One of my deep throat informants in Fall River, actually, this is a person I know whose family grew up in Fall River, and they lived down the street from the Bordens. Apparently, the story in Fall River is that the Irish maid helped her hide the evidence that she'd killed her father, and so it was the Irish who got her off. And those of you from Boston know the Irish and the earlier settlers are always fighting, so the Irish like that story. But basically, Lizzie had premenstrual syndrome, according to her defense in the trial. And this is an example. There are lots of others. There's some studies in England that show or suggest that people who get into trouble, who are female, very often get into trouble during the premenstrual sort of period, this late luteal phase dysphoria over the course of the cycle. Now, what kinds of physical signs and symptoms do we see here? Well, there's a little scale. Let me show you. I've got the Moos Menstrual Distress Inventory. Dr. Moos is a gentleman who is a psychologist down at Stanford University in California. And he, years ago, became very much interested in this condition and developed a questionnaire which could be given that covers these various points. The most common physical sorts of signs and symptoms that people experience have to do with breast swelling and pain, pelvic pain, headaches, skin disorders, backache, headaches, irritable, but then there are a whole bunch of sort of psychological things as well. Depression and anxiety are probably the most debilitating, but many people feel irritable, anxious, and so forth. As you can imagine, all of this is very difficult to quantify, and we've done some studies with this instrument ourselves, giving it to people at the end of every week. And even then, it's very hard to remember how you felt every day. It's something you almost have to give a person every day. And even then, there's so many things that affect how we feel in terms of depression and anxiety that you need many months of study before you're able to tell if this is something that's always present or if it's just something that's connected with your mother-in-law, father-in-law, job, or what have you. So basically what we're talking about here is not the same as simply menstrual cramps. It's earlier. Now let me just mention a few of the many dietary theories of PMS, and at the same time mention this excellent article that appeared in the American Journal of Clinical Nutrition in 1988. This was a study that was done, a very good study, which was done on women who said they suffered from premenstrual syndrome. And what they did, I think there were about 30 of them, they looked at plasma levels of several nutrients. They looked at blood levels of several nutrients: zinc, retinol, vitamin A, vitamin E, red blood cells, and then some tests of deficiencies of vitamin B1 and vitamin B6, and looked to see if the people over the course, people who suffered from premenstrual syndrome, seemed to be deficient in any of these particular vitamins or minerals, at least as detected by these plasma levels of nutrients during the course of their menstrual cycle, and particularly during this period, during the premenstrual mid-follicular phases of the cycle? And the answer was no. There didn't seem to be any difference. Well, that's just one recent paper. There are a lot of others. Let me just mention some of the theories of premenstrual syndrome that have to do with diet that have come up over the years. And I'll just mention them really fast and as examples of some of these unproven remedies. One is the B6 deficiency theory. The notion here is that vitamin B6 deficiency is what causes the disorder, and the remedy here is vitamin B6 supplements. And I'll show you some data later on, but most of you have probably seen it already, that suggests that this is not a totally harmless sort of treatment, at least when you get up into pharmacologic dose levels of B6 supplements. There are some effects. There's a very good paper that was reported a few years ago in the New England Journal of Medicine suggesting that there were some definite problems, including some neurological problems of peripheral neuropathy in the extremities due to very large doses of vitamin B6 taken by people who had premenstrual syndrome, thinking that they could correct it by doing this. A second theory, again, where we reviewed the evidence, we reviewed all of the studies which we could find, and had to judge that the therapy was ineffective, was the subclinical hypoglycemia theory. The notion here is that there is a hypoglycemia that people get, and that these folks are the people who suffer from premenstrual syndrome. In fact, the remedy here, of course, is an anti-hypoglycemia diet, a diet where you eat frequently and eat fairly large amounts of carbohydrate. Here again, if one looks at all of the data that we could find, and